as Matt mentioned, there's just a great deal, wide variations in care patterns. People in Florida get about 3 times as many doctor visits in their last 6 months of care. It reminds me of Dick Lamb's famous remark about all that we'd have to tell the elders in their last weeks of life is just don't get those Miami doctors, get Minnesota doctors who bother you 1/3 as much, and the people in Minnesota are happier than the people in Miami who are probably exhausted by all this parade of doctors cycling through their room while they're dying. A lot of inappropriate and avoidable care. One of the striking things now is in this model there is no business case for information technology. There's a very striking article in the Health Affairs a few weeks ago, Kaiser reporting on their experience in Hawaii, where they've completely rolled out their electronic system, which now has secure email with your doctor who has your complete record. And they found people who were taking advantage of that, and doctor visits dropped by 26%. Now, they thought that was great because the doctors felt now we can spend more time with the people who really need to see us. And the customers thought this was great because they don't have to leave their job and go to the doctor's office. They just ask a question. They could just enter the question and get the answer. So the problem is now in the fee-for-service solo practice sector, those doctors make money by doctor's visits. So this IT idea is really not very appealing. It's a threat. So it's not just that they don't know and government has to buy them computers, which won't solve the problem. So our whole healthcare system exists in economic gravity-free space, with the few unfortunates who have to pay it themselves. For the most part, there's no cost consciousness there. There's nobody making key judgments. Is this worth it or not? The way, let's say, I see my Stanford colleagues doing. I remember a few years ago, our CFO for the university, who's not poor, he's a MBA and so forth, wrote a letter to the doctors at Stanford University Medical Center who are not in an HMO. It said, you guys gave me, wrote it to Dean, said, you did wonderful care, I really appreciate what you've done and so forth, but I've looked at the money and you guys are just not worth the money, I'm switching to the HMO. Few in healthcare have incentives to innovate, to find better, less costly ways to treat their patients. Because if you're on fee-for-service, you're punished for finding less costly ways. And there's no built-in quality measurement and improvement. In fact, they don't even track what happened to you. Think about that now. You know, our doctors, unless you are in one of these IT-enabled systems that's famous for keeping records, you know, over a long time, then you go and you got some problem and the doctor treats you. The doctor has no systematic way of knowing what happened to you. By systematic, I mean he has a complete numerator, a complete denominator, so he can see the odds of this treatment versus that treatment working. I remember my poor father who died of prostate cancer. He was treated for a few months at Stanford University Medical Center. And I don't want to put down Stanford. It's the best place in the world, but it's not perfect. Anyway, so did all this treatment, and then he went home to Santa Barbara to die. Well, there's no continuous record, so they don't know what happened to him. They have no way of measuring, did all these drugs do any good or not? Whereas, again, if you are in a integrated delivery system with those records, well, there was a famous article a few years ago about Vioxx. The Kaiser docs were very suspicious of Vioxx for various reasons, but they used a little bit of it where the indications were strong, but they tracked those people, and then they teamed up with the FDA, did a study, and found that people who took Vioxx got more heart damage, and so they stopped using it altogether. Well, you only can do that if you keep records over a period of years and, you know, can track the patients continuously. Well, most of your doctors just don't really know what happened to you. You know, it's just at least unsystematic. So the solution is somehow universal health insurance based on competition among integrated delivery systems to deliver value for money to informed, cost-conscious consumers. Now, these delivery systems can take a wide variety of forms. We have in California some individual practice associations, and I think you've had some here. But the key thing is the docs are committed to work together to produce better quality and lower cost. They're usually linked by information systems. They're able to evaluate what they're doing. We need to emerge in a world where they are competing to produce value for money. So individual choice is essential. This cannot be done by the employment group. My employer doesn't know what's best for me. I look over the menu and I figure out what's best for me, but what I think is best for me just might be undesirable for somebody else. So I ought to be able to choose the most economical health plan, even if somebody else says, no, for me, I want wide access fee-for-service, and I'm willing to pay the extra cost. So it just shouldn't be that the employer narrows your cost and your opportunities. And in fact, employers do not offer choices. That's one of the biggest indictments of the employer-based system. Very few do offer choices, and those that do pay the whole thing whatever you do. So this model we're talking about rewards consumers for choosing, and therefore providers for organizing efficient systems. Now, comparatively efficient systems do exist. There is research that supports that. Dartmouth found that Intermountain and Mayo cost Medicare about 30% less, or 40% in the case of Intermountain, less than the national average. So there are more efficient systems. Group Health Cooperative in Seattle, about 30% less than fee-for-service there. So we need competing integrated delivery systems. We need sustainable growth, universal coverage, innovation in improving value, aligned incentives to choose and provide economical care. So the CED has proposed, and I hope you'll take home your CED report and study it in more detail, creating a federal agency, we refer to it as the Health Fed, that would create exchanges, which are places or websites where people can go look over the competing alternatives, click the one that they want, and maybe their credit card number or something. Exchanges to organize the markets. Then phase in mandatory exchanges, starting with small employers. The employers up to size 200 are in terrible shape in this system. They're not big enough to spread risks. Then cap the tax break at the price of an efficient health plan. And when everybody are in exchanges and the costs are contained, then use the savings from capping the tax break, those many tens of billions of dollars, to start increasing the subsidies for low-income people. And more would be paid for by a consumption tax. So finally, let me just conclude by saying the advantages of the CED approach include maximum incentives to innovate to improve quality, cost, and service, innovation in payment methods, and particularly important, market prices versus political prices. Political prices come out of the political process. What's going on with these very high-priced subspecialists, they make a lot of money and they recycle some of it into campaign contributions to the people who are deciding what their fees are going to be. But on the other hand, the poor primary care doctors don't have the money to do that, so they're relatively unpowerful. So we have shortages of primary care and surpluses of high-paid specialists. So this approach, another is compared to a single payer, this approach pays the low-priced plan, it's sort of like Stanford, for everybody, not fee-for-service, which is the high-priced plan, which typically is what single-payer proposals propose to do. Thank you.